A deep dive into Dermatitis Herpetiformis. Good morning, colleagues, and thank you for joining me today. Our focus is on a fascinating yet often challenging condition, Dermatitis Herpetiformis, or DH. This rare, intensely itchy, and chronic skin disease is intricately associated with gluten enteropathy, though many patients show minimal gastrointestinal symptoms. Let us embark on an in-depth exploration of its etiology, clinical features, investigations, and management. Introduction: Dermatitis herpetiformis is a condition that challenges clinicians with its dual identity as a dermatological and systemic disorder. While predominantly a skin disease, its close ties to gluten enteropathy demand a broader, multidisciplinary approach. Etiology: DH belongs to the group of immunobullous conditions, which are blistering eruptions driven by abnormal immunological reactions. Notably, up to 10% of patients with DH have a positive family history of DH or celiac disease, emphasizing its genetic underpinning. Furthermore, an association with thyroid disorders and other autoimmune conditions highlights its systemic nature. History: let us consider the patient history, starting with demographics. Age: DH most commonly presents between 20 to 55 years, though it can appear at any age. Gender: 2/3 of cases occur in males. Skin symptoms: patients often report a sudden or gradual onset of intensely itchy lesions. Symptoms can fluctuate in response to gluten intake, found in grains like wheat, barley, and rye. Gastrointestinal symptoms: while 90% of DH patients have celiac disease, only a few exhibit symptoms. Conversely, 15 to 25% of celiac disease patients develop DH. When present, gastrointestinal symptoms include fatigue, abdominal discomfort and bloating, diarrhea or constipation, weight loss, pale stools that float in the toilet pan. Clinical findings: the presentation of DH is distinctive, both in distribution and morphology. Distribution: symmetrical involvement, extensor surfaces of limbs, especially the knees and below the elbows. Other characteristic sites: scalp, scapula, and natal cleft. Morphology: small papules or vesicles grouped on erythematous patches. Blisters, 1 to 2 cm in diameter, are less common. Vigorous scratching often destroys vesicles/blisters, leaving behind erosions. Investigations: a comprehensive diagnostic approach is essential for DH. Blood tests: celiac disease serology, including IgA and tissue transglutaminase levels, FBC to check for macrocytosis, due to folate deficiency, and ferritin levels, to detect iron deficiency, which may be low even with a normal FBC. Skin biopsies: 2 biopsy types are necessary. Active lesion biopsy reveals subepidermal blistering on histology, with typical features often seen in the erythema around blisters. Perilesional skin biopsy, within 2 cm of the blister, for direct immunofluorescence, DIF. Samples must be handled carefully, either examined the same day or stored in a suitable transport medium like Michel's solution. Important note: patients on gluten-free or reduced gluten diets may show normal blood and biopsy results. To ensure accurate diagnosis, patients should consume a gluten-rich diet, e.g., 6 slices of bread daily, for approximately 6 weeks before investigations. Management: the management of DH involves a stepwise approach. Let us break this down into clear steps. Step 1: General management principles. Provide a patient information leaflet. Moderately potent topical steroids can offer symptom relief. Step 2: Dapsone and second-line treatments. A dermatology referral is essential as most patients will require Dapsone, which dramatically reduces itching within days. However, clinicians must remain vigilant for side effects: hemolytic anemia, agranulocytosis, rash, fever, sore throat, mouth ulcers, unexplained bruising or bleeding. Regular monitoring includes FBC, respiratory count, UE, and LFT. Patients must immediately report any alarming symptoms. Glucose 6-phosphate dehydrogenase, G6PD, deficiency. Screening for G6PD deficiency is crucial, especially in patients of Mediterranean, African, or Asian descent. as it doubles the risk of Dapsone-induced hemolysis. Alternatives to Dapsone: for those intolerant to Dapsone, options include sulfasalazine, 1 to 2g/d, sulfapyridine, 2 to 4g/d, sulfamethoxypyridazine, 0.25 to 1.5g/d. Other treatments, such as colchicine, prednisolone, and cyclosporin, are less effective and carry risks like an increased chance of intestinal lymphoma. Step 3. Referral to a gastroenterologist. A gastroenterology referral ensures investigation and management of celiac disease. Step 4. Referral to a dietitian. A strict gluten-free diet is pivotal. This dietary change has two critical benefits: reduces the risk of intestinal lymphoma, a known complication of celiac disease, improves DH control, allowing some patients to use Dapsone only periodically. Conclusion: in summary, dermatitis herpetiformis is a complex interplay of dermatology and systemic health, tied closely to gluten enteropathy. It requires a multidisciplinary approach for diagnosis and management, emphasizing gluten-free diets, vigilant monitoring, and patient